Dr. Arulraj Mugan to deliver his speech. He is one of the senior rheumatology faculties working in the government Rajaji Hospital at Madurai. He is having more than 10 years experience and he is actively participated in national and international conferences. I invite him for the speech.
Thank you, respected chairpersons, my teachers, senior colleagues, and my dear friends. So ideally this topic could have been given pre-lunch, but I hope you don't regret after my talk for having a sumptuous lunch here. Why diet should be given importance? So, in the recent past, you might have seen a lot of articles, and more so in the social media, you get a lot of messages about diets in so many diseases or various diseases, especially for rheumatic diseases. So, everyone becomes a doctor and gives some advice, tips for this diet. Literal meaning of diet is the food one takes habitually. So we have to advise the food or food items which everyone takes habitually. So you cannot give advice or ask them to take something which is unheard of. The diet may be pro-inflammatory or anti-inflammatory, which may have influence over the inflammatory diseases. Dietary metabolism can have an impact over the diseases like gout. A lot of studies focusing on the role of diet is coming up now. So non-pharmacological therapy may have a major role in future. More so, it is the most favored and glamorous therapeutic modality as far as patients are concerned. If you take a lot of time in giving dietary advice, patients will be keen to listen to you and you will get a lot of cases. So most studied disease is rheumatoid arthritis. There is an increasing evidence for the role of diet in either preventing the disease or preventing the flare of the disease. Low fruit and vitamin C intake was shown to be associated with doubling of the risk of rheumatoid. The highest antioxidant intake, beta-cryptoxanthin and zeaxanthin, is associated with lower risk of rheumatoid arthritis. How the diet acts? It acts through the intestinal microbiome. The increased understanding of microbiome in systemic inflammatory diseases like rheumatoid and where it shows filamentous bacteria in the gout, mostly gut. One of those microorganisms is Lactobacillus casei, has been reported to give autoimmune arthritis through their influence on T helper 17, Th17 cells. Dysbiosis impacts the innate pathways which lead to the production of pro-inflammatory cytokines, and probiotics, antibiotics and disease-modifying agents seems to modulate the disease process in rheumatoid arthritis. When there is dysbiosis, there is a leakage, capillary leakage and intestinal damage which spreads the inflammatory cytokines and the inflammatory cells to the distant organs. So whenever there is a dietary change, it alters the intestinal flora and it leads to local inflammation and increased permeability and leads to systemic spread of inflammatory cells and cytokines, leads to joint inflammation. One of the most popular diets tried in rheumatoid arthritis are said to be a favored diet is Mediterranean diet, which contains less red meat, more fish and olive oil, plant food with wine. Because of the high content of omega-3 fatty acids, it has some favorable antioxidant role. Then olive oil is rich in oleic acid and oleicanthal, which is metabolized into eicosapentaenoic acid, which is anti-inflammatory. In fish oil supplementation reduces expression of HLA-DR molecules on human monocytes. So there are so many mechanisms by which this Mediterranean diet can influence the disease pattern. Ideally, you should give 2.6 to 4 grams of EPA and DHA, but most of the capsules contain around 300 or 600 milligrams. So you have to give 6 to 8 capsules per day. There is conflicting evidence for the benefits of Mediterranean diet in RA. Some studies have reported decrease in pain and disease activity with Mediterranean diet. In a 12-week randomized trial, including 51 patients with RA, this dietary intervention demonstrated reduction in DAS28 and improvement in physical activity. These results can partly be attributed to antioxidant rich foods during the which is in the Mediterranean diet. Then latest one published in 2019, which says it's after analyzing the 7 systematic reviews, they have concluded that Mediterranean diet may make little or no difference in pain or disease activity and may slightly increase weight in rheumatoid arthritis patients, but the certainty of the evidence is low. On the other hand, it was not possible to clearly establish whether Mediterranean diet has any effect on functionality, morning stiffness, or quality of life, as the certainty of the existing evidence has been assessed as very low. These antioxidants are anti-inflammatory. So fruits, vegetables are the main source of dietary antioxidants, which contain vitamin C, E, retinoids, carotenoids, selenium, and lutein. So you should aim for 9 or more servings daily. Best sources are colored fruits and veggies. The darker or more brilliant the color, the more antioxidants it has. Good ones include blueberries, cherries, spinach, kale, and broccoli, which we don't routinely take. There are so many antioxidants present in our daily eatables like apple, tea, and other things like other beverages. So these are all antioxidants present in some of the fruits and vegetables, which have to be increased in the diet. Then they have tried gluten-free diet in rheumatoid arthritis. For 1 year, they have tried for 1 year. It has been shown to significantly reduce levels of antibodies, but clinically it was not demonstrated to be useful. Then elemental diet, which contains amino acids, no proteins, no whole proteins, mono or disaccharides, and medium and long chain triglycerides, supplemented with vitamins and trace elements. In a pilot study, they have involved 30 patients with active RA, which improved greater than 20% in early morning stiffness, and pain score and the Ritchie articular index was improved in 72% of elemental diet group and 78% of prednisolone group. So it is equivalent to 15 milligrams per day of prednisolone. Not bad at all. However, not all patients benefit with elemental diet, and this may be reserved for only select patients with rheumatoid arthritis. The recent developments, curcumin shown to have anti-inflammatory effect by blocking NF-kappa B, which inhibits neutrophil activation and synoviocyte proliferation and angiogenesis. Then selenium nanoparticles is again the recently studied molecule, which has some anti-inflammatory effect by modulation of the MAP kinase pathways and NF-kappa B, and which blocks the inflammatory cytokines. What about fasting in rheumatoid arthritis? So recently you might have come across so many Muslim patients asking you whether I can go for fasting during this Ramzan fasting. So fasting is good for rheumatoid arthritis. Reduction of pain and inflammation in rheumatoid has been established with fasting. But reversal of remission is also known following resumption of regular dietary habits. The benefits with fasting in rheumatoid, if any, are transient and may not have long-term implications in disease activity. There are certain diets like red meat should be avoided, and corn oil, which contains omega-6 fatty acids, that has to be avoided, and fried processed food, sugars, high carb diet should be avoided because it can increase advanced glycation end products. Then something about alcohol. Red wine has a compound resveratrol, which has well established anti-inflammatory effect. The studies have shown wine consumption is associated with the reduced risk of knee OA, and modest drinking is also associated with the reduced risk of rheumatoid arthritis. So other research shows alcohol's detrimental effects on arthritis. Overall, everyone agrees there are not enough health benefits in alcohol to start drinking if you don't already do it. But if you do enjoy an occasional adult beverage, drink it in moderation. The general recommendation is 1 drink a day for women, 2 for men. In excess of that, you will lose the benefits. They become pro-inflammatory. Diet in osteoarthritis. Of various dietary supplements have been tried. Of these, 20 supplements have been investigated, and among this, 7 supplements: collagen hydrolysate, passion fruit peel extract, curcuma longa extract, boswellia serrata, curcumin, pycnogenol, and L-carnitine demonstrated some clinically important effects on pain reduction. Then another one is green-lipped mussel extract. So I don't know who eats, maybe Chinese eat this. And undenatured type 2 collagen had clinically important effects on pain at medium term. No supplements were identified with clinically important effects on pain reduction at long term. Chondroitin demonstrated statistically significant but not clinically important structural improvement. Another study is a systematic literature search was done reviewing this articles, peer-reviewed articles, which shown that glucosamine and chondroitin sulfate have shown robustly to delay the progression of knee OA in several well-designed studies. So nothing wrong in using this chondroitin glucosamine components. However, more controlled clinical trials are needed. Then of course, vitamins in OA, vitamin C and D intake were shown to be associated with lower cartilage damage, which is studied by MRI. And coming to the gout, the sufferer must, for the gout, the dietary restriction and other restrictions should be that. The sufferer must also enter into a solemn compact with his stomach to relinquish all serious flirting with the sirens of the kitchen and the houris of the wine cellar. So I did not know the meaning when I took up this. So I verified in the dictionary, and I found that houris are beautiful young women who accompany the Islamic clerics in those days. So you have to give away with that. Then sirens of the kitchen is they organize tour excursions for training the cooking classes. They go to exotic places and they enjoy and they learn cooking classes and all drink wine and everything. So you have to give away all these things if you have a gout. This was the saying by Reverend Sidney Smith, who was a sufferer of gout. Avoid high carb diet, meat, protein, seafood, and purine-rich vegetables, fruits are not associated with increased risk of gout. Dairy products may exert a urate lowering effect. Beer has the largest purine content among the alcoholic beverages. Fish oil capsules instead of fish can be given to these patients. So tart cherry juice, it's shown to have some effect to prevent flares, but look at the cost. 8 ounces daily should be given. So one bottle of 8 ounce costs around 1,250 rupees. 16 ounces bottle, sorry. So what is a magical elixir? Anyone knows what's a magical elixir available now as on date for gout? It's water. There is magical elixir to drink, it's water. Hydration is vital for flushing toxins, which can help fight inflammation. Adequate water can help keep the joints well lubricated and can help prevent gouty attacks. Then SLE and diet omega-3 fatty acids, they are more useful. And to avoid alfalfa sprouts, which contains L-carnitine. And the another one I saw in the net is garlic. I don't know whether you need a lot of studies, but there are no studies. Garlic contains allicin, joni, and thiosulfonates. Yes, carry home message. I have come to last slide. So, you advise your patients to take 3 to 4 ounces of fish, 1.5 ounces of nuts daily, 9 or more servings of fruits, olive oil 2 to 3 tablespoons daily, beans about 1 cup twice a week, and eat a total of 6 ounces of whole grains. 1 ounce of whole grain would be equal to half cup cooked brown rice or 1 slice of whole wheat bread. So it's out of the context. Do you know types of vegetarians? Lacto-ovo vegetarians, vegetarians who avoid all animal flesh but do consume dairy and egg products. Lacto-vegetarians, vegetarians who avoid animal flesh and eggs but do consume dairy products. Ovo-vegetarians who avoid all animal products except eggs. Vegans, vegetarians who avoid all animal and animal-derived products. Those who do not eat meat or poultry but do consume fish are considered pescatarians, whereas part-time vegetarians are often referred to as flexitarians. Thank you.
Thank you for the interesting lecture, sir. A lot of preparations containing collagen is being marketed for osteoarthritis. Do you think they are useful?
So next week I am giving a talk on osteoarthritis in Bangalore. So how do I treat? The topic is how do I treat? I treat with collagen. I treat with nutritional supplements. I find very good response in osteoarthritis. All the studies have shown that this molecule has some effect. This molecule has some effect. Like this, there are so many nutritional supplements which have some effects. So if you sum up all the sum effects, it becomes significant effect. So you can try all the molecule and you will have good effect.
Sir, Arul sir, what is your take on keto diet for patients with rheumatic diseases? Because nowadays keto diet become very popular. Patients come and ask whether inflammatory disease, rheumatoid arthritis or osteoarthritis, can we take keto diet? So what is your opinion on keto diet in rheumatic disease?
There are no studies available for keto diets as of now. So I don't have any idea about this keto diets, but I ask them to avoid keto diets. I don't advise keto diets.
We shall close the session. We'll close the session.
Thank you.
Thank you. So the next talk is on Iguratimod in rheumatoid arthritis. The chairpersons are Dr. Krishnan Kutty and Dr. Jacob Matthew.
It's my honor to introduce Dr. Subramaniam. He's a senior consultant in Tirunelveli, a very needy area. On the lighter side, we rheumatologists, we all love tongue twisters. I think it can't get any better than this Iguratimod or Iguratimod, whatever you call it. Please, Dr. Subramaniam.
Good evening to all respected chairpersons, my teachers and other colleagues and organizers of the South Zone team. It's really a great pleasure and honor to talk on new drug, Iguratimod in rheumatoid arthritis. So we all know rheumatoid affects women of younger age, and Methotrexate is the most commonly used DMARD among Indian RA patients. But there is still a lot of unmet need because Methotrexate is not tolerated very well and has side effects, and there is also a concern about other complications. And yes, the biosimilars and biologics are being used in those patients, but not all of them do respond to our drugs. So the need of the hour is which would be a better molecule for patients who do not tolerate Methotrexate or other DMARDs and who cannot afford for Indian patients. So whether you could have a novel small molecule, it could be oral, like tafasitamab, and long-term safety and improve quality of function, whether it can be used with other DMARDs. So the talk is yes, treatment of active rheumatoid. Iguratimod, how does it find its place? And it's a new drug. So if you Google it, it's only 24,000 references so far for Iguratimod. It's originally developed in 2012 back in Japan and China, and most of the references are from those two countries so far, and slowly it has been launched in India since March 2019. So the chemical structure is like small molecule DMARD, so it's related to anti-inflammatories, fluozoid and limasolide. It has a chromone core framework, and it has anti-inflammatory and immunomodulatory functions. Indications, it has been used as an add-on therapy for people with active rheumatoid who are not responding to methotrexate, or who are intolerant to methotrexate, or inadequately responding to bio-DMARDs. So the dosage is 25 milligram per day for the first 4 weeks, followed by 50 milligram a day or 25 milligram BD subsequently. That's the maintenance dose, which is the maximum. So it's marketed as Mimod in India. So the multiple mechanism of action, you can, it suppresses the production of IgM and IgG, and also inflammatory cytokines. We all know, cytokine mediated disease, most of the rheumatology disease, interleukin 1, interleukin 6, and also TNF. And it also inhibits the COX-2, and it has a good anabolic effect on bone metabolism by stimulating osteoblastic differentiation and inhibiting clastogenesis. So way back in 2015, ACR special editorial review recommended Iguratimod as add-on therapy who cannot take methotrexate. So I'm just going to focus on the clinical evidences which we have as of now. So that's the landmark trial back in 2008 in China. So T614, it was the first one. So double-blind randomized placebo-controlled multicenter trial. They separated patients from used on placebo, and then 25 milligram daily and 50 milligram daily, fairly equal number for 24 weeks. So the drug showed therapeutic effect within 8 weeks of starting treatment. So that's you can see the disease activity scores and also the assessment scores, ESR and CRP, compared to placebo. So the CRP and the disease activity scores have improved on 25 milligram and also 50 milligram, including the HAQ score. The side effects reported in those studies were GI discomfort, leukopenia, and liver enzyme derangement, which fairly we come across in patients using methotrexate too. So that was the first reported study of patients with rheumatoid and Iguratimod. It's slow-acting drug, so it takes 4 to 6 weeks. So this was the second one. They compared with methotrexate, again a double-blind control study. So they fairly equal number, 160 patients in each group. And the third group, you can see methotrexate for 4 weeks and subsequently increased to 15 milligram weekly. So the efficacy, no significant difference in ACR-20 improvement in group 2 and group 3. But compared to placebo, both were better. So it means it's superior to placebo, but equally efficacious with methotrexate, as methotrexate. Side effects were fewer and milder than methotrexate, and again side effects were the similar from the compared to the first study. No GI and cardiovascular adverse events. So that was the conclusion. It could be a new option for treatment of patients with active RA. So this was a study in 2007 compared with placebo and sulfasalazine in active RA. So sulfasalazine was given in the group 2 500 milligram or 1 gram BD, and the third group was placebo. So it did show that in 8 weeks, Iguratimod showed a 41% response rate compared to 30% of sulfasalazine. So it's non-inferiority study, although it's a small number, but p-value is significant. So adverse events compared to sulfasalazine, no significant difference. So they concluded that it could be effective in patients who do not respond to DMARDs at the time. This was compared with methotrexate and non-responders or inadequate response. But it's an extension study, double-blind study too. So patients move on to Iguratimod after initial period, and these patients were longer duration patients, patients who had treatment for a few years, maximum 10 years. So switching to Iguratimod helped improve disease control even at 52 weeks, ACR 20, 50 and 70 across the board. And that's also depicted in this. So the disease activity is well controlled with the those patients who had high DSR, so high DAS28. It's nearly 1/3 of patients showed remission, both groups. And longer term, 1 year, the side effects were similar. So the conclusion was combination therapy is efficacious and tolerated for at least a year. So it could be patients who are suboptimal response to methotrexate or failure of biologic agents too. They suggested, but it was in 2014. So this was a study in 2018. So those who do not respond to bio-DMARDS, so they analyze, although it's a retrospective study. So the bios used were pretty much all of them etanercept, adalimumab, tocilizumab, golimumab, but not rituximab. So this duration was 6 months, and 38% achieved clinical remission overall. And they also looked at the power Doppler to ensure that the disease is gone into remission. So that's the graph showing very good disease control. So those patients who do not respond to bio-DMARD, this would be an ideal option. This is a study, again, it's a 3-year efficacy study. This is a common in clinical practice patients. So survival rate of patients who had been on therapy, it was 40%, and disease activity was reduced in Iguratimod group and also the combination group. Sustained low disease activity even by 3 years. So it was effective without methotrexate or bio-DMARD, or as well as in combination with methotrexate. And they found out that female gender, no use of prednisolone and a low DAS28 CRP were associated with good clinical remission. So that means there's a mild disease activity anyway. This was a study as a longer term safety profile, so up to 52 to 100 weeks. So the dosage is the same. ACR-20 response was 47% at week 28, and at the end of 1 year, 41%. And blood concentration also they looked at for first 16 weeks and they remain unchanged. So continued treatment for more than 100 weeks, and some of them have been on for 7 years. It's predominantly like Japan and China, those patients were from. So the conclusion was Iguratimod could be used with a longer term also, but close look at hepatic enzymes for regular monitoring, which we all do anyway, those patients who are on methotrexate every 3 months. Then they also published or presented in the EULAR 2014 3 years data from their patients as a middle term outcome and their clinical use. So basically they said the prednisolone usage can be reduced or even stopped while replacing with IgU. It was also tolerated very well. This was published or presented in ACR 2014. So DAS28 CRP, ESR and the disease activity significantly reduced from 18 to 4 in 24 weeks. So this is a safety, it's a review article in 2013, systematic review which they had so far. So it's relatively safe and effective in treating RA, and similarly efficacious compared to methotrexate and sulfasalazine. So the thinking was whether it could stand in place of these two drugs in terms of safety. This was published last year, 2019. So it could can inhibit the activation of nuclear factor kappa B and thereby production of rank ligand. So its osteogenesis can be also involved in this, and that shows the radiological control, or people can avoid, reduce erosive disease. So it's a 2-year study over in Japan. So 2 years by 52% of patients showed no progression radiographically. So in a nutshell, so the clinical studies so far available, so Iguratimod has similar efficacy like Methotrexate. Safety, they claim it's better, but combination therapy superior. If you look at with studies with sulfasalazine, it is a non-inferior study, and the onset of action is similar to sulfasalazine. Leflunomide, except one in vitro study, we don't have in vivo studies, and there is a suppression of IL-17 signaling in that study. And if you add on Iguratimod with Methotrexate, then they do respond better. So these are contraindications from the pharmaceuticals. As a pregnant woman, patients with severe hepatic dysfunction, peptic ulcer, history of hypersensitivity, and warfarin therapy, do not recommend. Common adverse effects documented include nausea, abdominal pain, GI symptoms, cytopenia, liver enzyme elevation, and interstitial pneumonia, peptic ulcer, nasopharyngitis. So if you look at the summary, so novel synthetic DMARD, which can work for patients with methotrexate intolerance or suboptimal therapy and who cannot afford biotherapy. So it's approved in 2012 in Japan and China. ACR guidelines suggest it could be used as add-on therapy to these drugs. Efficacy is similar to methotrexate, and it's non-inferior to sulfasalazine. So 3-year efficacy is very good, and the long-term safety is also up there, slowly coming. So I would suggest people who do not respond to methotrexate, sulfasalazine very well, or have side effects in tolerating it, then yes, this could be an add-on therapy. Yes, those patients who cannot go for biosimilars or biologics. And the cost is roughly around 19 rupees per 25 milligram tablet. So for patients, that's also better. So that's the Agenta Pharma, which is one marketing memo. That's one available from March 2019. So although it was approved, the Indian studies were done in 2016. So it's not published, but they used it for approval process in the CDSCO, which is the Controlled Drug Safety Organization. So that also showed a beneficial effect similar to Japanese patients in Indian patients. So with that, I would like to thank our team, organizers, and also the chairperson for giving me this opportunity to talk. Thank you. Thank you very much.
Thank you, sir, for your nice presentation. A new molecule introduced by Japanese and approved by China. It is essentially in use in 2 countries. It may be useful in India in between conventional DMARD and biological DMARD, because it is a oral and less costly than biological DMARD.
Indeed.
It is going to have a nice place in between DMARD and biological agents. The topic is open for discussion.
I'm happy to listen to you and our colleagues' experience. I haven't used myself.
So one question here. So when there is a side effect of pancytopenia here, is it a idiosyncratic pancytopenia or over a period of time pancytopenia develops?
I can't answer that question. So
Used in 15 patients, but only problem is raised liver enzymes. So after, you can see immediate response. After 4 weeks, there is a very good response. The disease activity, ESR-CRP comes down. Even one of my patients had a large effusion of the knee joint. After starting this memo effusion disappeared after 4 weeks. Even I was surprised to see the effect. So that's how I started memo for other patients. So it works, but you have to see for the long-term effects. But only thing is you have to closely monitor like sulfasalazine every 15 days during the first 3 months, liver enzymes and cell counts. So otherwise the drug looks promising. Maybe we have to wait and see.
Thank you.
We will allow only one more question.
You
along
can.
with methotrexate.
You can.
I have not given it as monotherapy.
Very exciting topic.
Kindly allow few questions. New molecule.
New molecule.
The
Yes, yes,
audience should not go with the wrong impression.
Yes, sir.
Please,
Go ahead,
5-10
sir.
minutes, no problem.
Please, sir.
Okay, sir. Subramaniam, is there any data in patients with interstitial lung disease? First question.
No.
And second thing is, is there any
Rajkiran,
data in
be your
combination-
question.
Is there any data in combination with biologics? Memoed with biologics and memoed in the setting of background ILD?
I mean, the data available so far, patients who are not responding to biologics are not responding to the adequate dose of methotrexate. So they haven't combined. Answering to the first question, no, because of the side effects of interstitial pneumonia, so patients who are already had ILD, they don't get this treatment.
Is there any data with patients with renal impairment?
Patients with?
Renal impairment.
No, we don't have the data, sorry.
Sir, see your presentation, you address DAS 28, means only primary outcome, that too in combination. The second outcome, you are not addressed. Where you keep the molecule? Is symptom modifying or disease modifying or structure modifying?
It is disease
That's,
modifying.
we cannot take a decision like this. It is indicated on RA. EULAR guidelines in one place it is there as add-on therapy. Add-on therapy as a symptom modifying or disease modifying.
I mean,
Unless the ACR 50, ACR 75, SASP score are addressed, we cannot support this molecule. So always data coming from Japan and China, we have to take with pinch of salt.
yes, I agree.
One final comment by Dr. Taba. One final comment.
Work and can it be used as a single agent?
The studies show it does help. It's an add-on therapy. So although it can be used. My take is probably it is replacing steroids and anti-inflammatories because there's more anti-inflammatory than disease modification. So it would take the role of steroids and NSAIDs and also part of methotrexate, which was described as IL-1 IL-6 blocker and also nuclear kappa factor B reduction.
Thanks for the nice presentation. Couple of questions. Do you have information on, it was presented in ACR.
Okay.
What's the FDA opinion on this drug? Second is what is the EMA opinion on this drug, European Medical Agency? And third, I presume DGCI approved it. Is that right?
Yes, it's approved in India as per the company's recommendation from March. They have got the approval.
Okay. Was it for a trial or for prescription?
For prescription.
Prescription. So what is the FDA and the EMA?
That I haven't looked.
Because one of the reasons for probably the skepticism is most of the papers are published in 2007 to 12. And despite that, it's
indeed.
coming in 2019.
Yes.
So that leads to a lot of skepticism, and FDA and EMA are not into it.
Indeed.
When the
Yes.
Western world doesn't take it up, it's difficult to promote a drug. But that doesn't mean it doesn't work. But that leads to
Exactly. So the first study was 2007, 2008. So looking at the other side, biosimilars, they all been started initially from East Asian countries, and it took nearly 7-10 years for the US and UK approval for the biosimilars. So similarly, there is a longer time because of the studies, the nature of studies vary in East Asian countries. And the population, genetic ethnicity variations.
The molecule is introduced by Japanese and widely used in China. Don't underestimate China now. Previously, Chinese products are inferior. Now, everywhere in the world, we are using Chinese products.
Actually,
so don't underestimate China.
Actually, 2003, this was submitted for approval, but the approval got cancelled even by the Japanese authorities. Then it was reintroduced in 2009. Though the molecule was discovered in 2000, it has come to the practice only in 2012. Most of the studies are 2007. Most of the studies quoted are 2007.
Yes.
But the final approval they are given after 5 years. And after 7 years, it has come here. So initially, even in Japan, it was submitted for approval and withdrawn by the company in 2003 and reintroduced for submission for approval in 2009. So we do not know the reason why it was removed from the approval also for about 6 years.
I think we'll close the session here.
Insufficient data.
Due to time limitations. Thank you, Dr. Subramanian. Thank you.
Thank you. The next session for today is drug-free remission in rheumatoid arthritis. The speaker for this session is Dr. B. Padma Kumar, and the chairpersons are Dr. Jijit Krishnan and Dr. Yatish. For more questions to be allowed, the speakers are expected to finish the speech in at least 12 minutes so that we don't exceed the 15 minutes of time.
Very good evening for everyone. So topic is drug-free remission in rheumatoid arthritis. So this is an ideal situation where every patient will ask this question. So when are we going to stop the drugs? So I think most of us, at least I have failed to answer this question. So let Dr. Padma Kumar help us in answering this question. Thank you.
Respected chairpersons, senior colleagues and dear friends. During the last few decades, the target of the treatment of rheumatoid arthritis has changed from simple symptomatic relief to prevention of disability and radiological damage, and also to have a near remission or cure. During the Hippocratic days, the expectation of the treatment was cure sometimes, treat often, and comfort always. But due to the introduction of newer therapeutic modalities and also because of the early diagnosis of many conditions, nowadays we can dream about reaching a remission or a cure of many of the chronic conditions, including rheumatoid arthritis and even diabetes and cancer. Coming to the remission, there are two types of remission we can describe in rheumatoid arthritis. That is, one is sustained remission, which allows the withdrawal of biological DMARDS and tapering of the conventional disease-modifying agents. To another step, or one more step, or one step ahead is the drug-free remission, where there is a theoretical possibility of cure, where remission is sustained even after disease-modifying agent discontinuation. Now coming to the definition of remission, the most widely accepted criteria is the ACR-EULAR criteria. It is different for clinical trials as well as for clinical practice. For clinical trials, the Boolean criteria, which includes the swollen joint count, total joint count, tender joint count, then the patient global assessment as well as CRP, all should be less than 1. Whereas in case of indexed brace criteria, the simplified disease activity should be less than 3.3. It is different for a clinical practice, where the Boolean criteria has excluded the CRP and all the other criteria were included. And in the index-based criteria for the clinical practice, they have included the clinical disease activity index should be less than 2.8. We know this DAS28 ESR as well as DAS28 CRP is also widely used for the clinical assessment of the remission in various clinical practice. Now coming to the method of achieving a total cure or clinical remission in rheumatoid arthritis, there is a 6T model to manage rheumatoid arthritis effectively and achieve remission. There are 6 T's. One is the time to treat, the treat to target, as well as the targeted therapy. Of this, the time to treat is the most important thing. Hit early and hit hard is the most important concept in the first 3 months, which presents a window of opportunity during which we should act and try to achieve a remission. That is the most important time where we can act. And as we all know, the phase of rheumatoid arthritis includes a pre-disease phase where it is very difficult to make a diagnosis because it is the preclinical phase. There may not be any clinical features, no symptoms, or there is only mild arthralgia. The next phase is the optimum stage for our therapeutic action, where it is a reversible autoimmunity that is there, and also there is a better prognosis in case of early and aggressive therapy. So most of these studies regarding this remission says that therapeutic response in the first 3 months of therapy predicts the potential of reaching remission later. So this is the most important aspect of achieving a remission, that is the time to treat. And many other studies also shows that according to the concept of the window of opportunity, aggressive treatment in the early phase of the disease may lead to excellent improvement and sustained benefit. So the time to treat concept is the most important part. The success of any treatment depends upon mainly 3 factors. One is the early diagnosis, the effective drugs, as well as the treatment guidelines. For rheumatoid arthritis, luckily we have got a 2010 ACR-EULAR classification criteria, which makes us to help us to make a diagnosis of rheumatoid arthritis before within few weeks, which is much earlier than the 1987 criteria. That is one thing. And we have effective drugs also. We have these conventional disease modifying agents as well as the biological disease modifying agents, and also we have management guidelines also. So proper utilization of all these 3 facts may help us to achieve the dream state of remission in future. Proper usage of the conventional disease modifying agents as well as the biological disease modifying agents in the window of period itself may help us to achieve the remission. Now coming to the treat to target concept of achieving the remission. Most of these trials, like the TICORA trial, the BEST trial, all these trials have showed that a strategy of aiming for low disease activity or remission is more important than the choice of a specific agent. So the targeted therapy approach is the most important thing, where the usage of the biological disease modifying agents, which has produced a revolutionary change in the management of rheumatoid arthritis, and also the rapidity of response is much better with the biological disease modifying agents than the conventional disease modifying agents. So these are the 6 T's which are involved in the management of rheumatoid arthritis to achieve the remission. And which are the factors that are associated favorably with remission? Most of the meta-analysis have shown that the male sex, the younger age, the late onset of rheumatoid arthritis, the short disease duration, non-smoker, a low baseline disease activity, and mild functional improvement, mild functional impairment, then low baseline radiographic damage, the absence of the rheumatoid factor and anti-CCP, low serum level of acute phase reactants, and also certain genetical factors, especially the presence of MTHFR 677T alleles, etc. And the early treatment with these synthetic disease modifying combinations, agent combinations, the use of anti-tumor necrosis factor, and concurrent use of disease modifying agents in anti-TNF treated patients, and finally moderate or good response to treatment at the first 6 months. These are the factors which can favor or predict the development of a remission if we act properly in patients with rheumatoid arthritis. And remission is less common in older patients if they are more than 50 and last for a shorter time. That also we have to accept. And there are certain factors which reduces the chances of remission even though we timely act, including coexistent infections, then presence of diabetes mellitus, cardiovascular disorders, and obesity. So these are some comorbidities which can impair the chance of or prevent the chance of achieving a remission even though we act properly. Which are the advantages of remission? Definitely it has got many advantages, including it improves the function and survival prognosis, it reduces the mortality in patients with rheumatoid arthritis. Most important is chance to regain remission after flyer is again high if we once achieve remission. Then it reflects the normalized health state and survival expectations close to those in the general population. So these are few, especially reduces the mortality. That is one of the important advantages of remission. There are several studies regarding the definite time frame to assess the remission, when we had to say that the patient is achieving remission or how long we had to monitor. In the observational setting, a 3-month monitoring has been shown as the minimum time frame to assess the remission. And also, we should have a definition of the duration of the remission also. The most often applied time frame to define sustained remission before tapering or withdrawing of the treatment is 6 months. There are several studies which assess the matter of this remission in rheumatoid arthritis. Of this, the most popular as well as the well accepted study is the BEST study, where they have studied a sustained responses after the termination of a biological therapy. About 508 patients were studied. Patients with early rheumatoid arthritis were treated initially with Methotrexate. Then they randomized them to treat with infliximab or placebo for 12 months, and they again followed the patient for an additional 12 months. At 12 months, the ACR-50 and ACR-70 responses were better in the Methotrexate plus infliximab group, that is a conventional as well as a biological disease modifying agent group. No new reversions were found and MRI scores were better than MTX plus placebo group. That was their observation. 1 year after discontinuation of infliximab, that is after the biologicals were removed, 70% of the patients still had sustained excellent clinical response with Methotrexate alone. And which are the predictors for sustained biologic remission in this study? It was this rheumatoid factor as well as ACCP negativity and non-smoking as well as shorter anti-TNF treatment. Now, regarding the possibility of drug-free remission or cure, is it possible? Again, there is an answer in the BEST study. About 13% of the patients were in medication-free remission after 4 years. They were not at all having any biological or conventional disease-modifying agents after 4 years. Male gender, lack of anti-CCP and short symptom duration were associated with drug-free remission in these patients. So, initial combination therapy with Methotrexate and infliximab led to most favorable result in terms of drug-free remission. That was the observation in the most popular BEST study. And which are the factors that improve the sustenance of remission after discontinuation of the disease-modifying agents? Early targeted treatments, including biologicals as well as the synthetic disease-modifying agents, irrespective of the initial treatment strategy, and also subsequent strict monitoring of the disease state during the whole follow-up were the important factors which confirmed the possibility of a remission even after the discontinuation of the disease-modifying agents. Then there are also studies with remission where they have tried tocilizumab. About 108 patients were studied. 10% of the patients were able to discontinue tocilizumab therapy. Low matrix metalloproteinase 3 and low serum IL-6 levels were predictors of low disease activity in this study. Induction therapy followed by maintenance. That was the final conclusion in most of the trials where they have attempted the remission in rheumatoid arthritis. Initial induction treatment with biologicals plus conventional disease modifying agents in the initial window period, that is in the 3 months period, and following that a maintenance therapy with a conventional disease modifying agents. That was the most accepted therapeutic program in most of the studies. Most of the studies were tried this remission as the most important factor. The HIT-HART study, PRICE study, the RRR study, all these were adopting the same method. Initial induction followed by a maintenance phase. Which are the barriers to remission? That is most important for us also in a country like India. Large percentage of the patients come well outside the window of opportunity. That is the one most important negative aspect of, especially for us. And then current pricing of the biological disease modifying agents make it out of reach of the vast majority of the Indians. That is the most important aspect when we are discussing the remission in our country, barriers. Still there are rays of hope. That is, emergence of biosimilars are giving hope for us regarding the economical aspect, and emergence of the small molecules, especially targeting various intracellular pathways like the JAK pathways, SYK as well as the BTK pathways. These are giving hope for us in the coming near future for considering the remission. So, in the future regarding the remission, we had to consider certain facts. There are certain limitations for this ACR remission criteria, ACR-EULAR 2011 criteria. The role of imaging were not at all considered in the criteria. Then the most important aspect of symptom of this rheumatoid arthritis patients like fatigue is not at all considered. Improvement of other joints, involvement of the other joints like the ankle as well as the foot were also not considered in the criteria, and CRP also not included in the clinical disease activity index. These are certain drawbacks of the most popular ACR remission criteria. So in future, we need more studies to select the most favorable treatment strategies. The roles of disease duration, environmental and genetic factors should be investigated. reliable biomarkers to identify the patients also have to be identified. And finally, understanding the mechanism of the drug-free remission at the molecular level also we had to study. That is all. Thank you very much for giving me this opportunity, especially to the organizing members of the Sziracon 2019.
Thank you for the excellent disposition of the topic. I hope there will be suggestions or discussions on the topic.
Thank you, sir. Thank you.
Does early treatment with JAK inhibitors achieve this drug-free remission early, sir? JAK inhibitors as first-line management.
There are only few studies I came across using these JAK inhibitors in early rheumatoid arthritis, and there are mixed results. Few studies shows good response, especially in younger patients, and rheumatoid factor ACCP negative patients, they have good response.
See, this drug-free remission, you say drug-free, but how long they are followed up and what is the relapse rate?
The most popular study is the best study, where they have followed the patient for about 4 years, and the patients were totally out of drugs and they were in remission as per the criteria. Most of the studies have followed the patients for 2 to 3 years, where they were not at all using any drugs. So the minimum time duration that is accepted for saying that there is remission is 6 months.
Dr. Padma Kumar, my compliments. A good presentation, good evidence-based shown. But issue is 7 to 10% of RA going to have spontaneous remission without treatment.
Yes.
They may be 3 months, 6 months, or 2 years.
Yes.
We don't know today any biomarker to identify that group of patients. So this drug-free remission, how many are due to spontaneous remission, how many due to drug? That differentiation be difficult.
Exactly, sir. That is an important matter that is set to be discussed, because rheumatoid arthritis is a chronic disease. In certain percent of the patients, it can undergo spontaneous remission also. We don't know whether it is the effect of the drug or not. Yes, sir. Well taken. Thank you, sir.
If there are no further questions, I think we'll close the session. Thank you.
Thank you, chairpersons and speaker. We will next move on to inhibition of radiographic progression in SPA, whether the evidence here can be translated into clinical medicine. The chairpersons are Dr. M. Saravanan and Dr. P.S.R.
Hello. Yeah. After yesterday's beautiful presentation of MRI in spondyloarthropathy to diagnose this thing, today we are talking about inhibition in radiographic progression. Yeah. Over to Subramaniam.
Good evening. At the outset, I would like to thank the organizers for giving me the opportunity to address this August gathering. Thanks a lot, Association of Rheumatology of Tamil Nadu. I'm asked to talk about inhibition of radiographic progression of spondyloarthritis. I would like to disclaim that this is a Novartis sponsored session, and slides from Novartis team has been acknowledged. Also, I would like to mention in one statement that most of the slides are mine. It's not from Novartis. Okay, so this is what we have learned, or this is what's the usual diagram that we usually teach the undergraduates on how a spondyloarthritis usually progresses. What has changed over the years is probably from this stage, we are now looking at this stage whenever after the advent of TNF inhibitors or continuous use of non-steroidal anti-inflammatory drug. And when you are talking from this stage to this stage, what we are looking at is the osteoproliferation in the spine. Okay, osteoproliferation in the spine, and what has caused the reversal of this osteoproliferation in the spine is probably the tumor necrosis factor alpha inhibitors. So with this introduction, just like in RA we have got treat to target, we are looking at whether this strategy is possible in diseases like spondyloarthritis. First of all, we have to know that spondyloarthritis, again, it's a heterogeneous disease, just like most rheumatic diseases. So, what has this tumor necrosis alpha treatment done? It has caused a dramatic relief in advanced stages of osteoproliferation and radiographic sacroiliitis. So, this set off a theory whether TNF alpha inhibitors will actually prevent long-term structural damage and radiographic progression in spondyloarthritis, and hence we are looking for an early reliable diagnosis in ankylosing spondylitis, which becomes a central point for appropriate management. So, again, this sets off the usual conundrum of inflammation, disease activity and damage. I would not like to dwell too much upon this particular conundrum at all, as it's well known in most of the rheumatic diseases. So what has changed? This is actually the classification in the pre-biologic era, and this is the classification in the biologic era. So this is the modified New York classification criteria for ankylosing spondylitis, and this is ASA's classification criteria, where in modified NY classification criteria, you're looking at radiographic sacroiliitis, and in the ASAS criteria, we are looking at the MRs. What we usually tend to do in rheumatoid arthritis is we usually tend to look for bone marrow edema in the hand, in the wrist joints or in the metacarpopharyngeal joints, which depicts early inflammatory arthritis problems. And this is what we see in STIR images. But what we tend to neglect is the fat metaplasia that occurs in the T1 weighted images, which we usually don't ask for when we screen for a patient of spondyloarthritis. When we tend to do STIR images and look for bone marrow edema. Whether looking for bone marrow edema is it or not, we're really not sure, and I'll come to the points in the subsequent slides. So what is this treat to target paradigm in axial SPA? So T to T means there is a clear target, and we are trying to achieve a disease state or a disease remission or a low disease activity which is sustainable over a period of time. So in spondyloarthritis, most of the loss of function is because of a new bone formation or joint fusion, and the progression is definitely non-linear. What I mean to say when it's non-linear, there is a stage of intense disease activity followed by periods of quiescence and with no progression or damage. So this is where the progression of the disease per se is non-linear. And of course, you have got phenotypes of this particular disease which are more prone for progression of spondyloarthritis or rapid progression of spondyloarthritis, thus leading on to osteoproliferation and finally a bony ankylosis. I was searching through the net, and probably the best diagram or the best chart is from this Professor A.N. Malvia's paper, which classifies non-radiographic spondyloarthritis on phenotypes which will progress onto radiographic spondyloarthritis. Wherein in non-radiographic spondyloarthritis or non-radiographic SPA, we have got a clinical spectrum, a radiological spectrum depicted by MRI, and this radiological spectrum was possibly is to identify the bone marrow edema on MRs. This is the radiological spectrum. And in radiographic SPA, we basically have radiographic SPA without osteoproliferation as depicted by grade 2 and grade 3 sacroiliitis, or radiographic SPA with osteoproliferation, which defines a fused sacroiliac joint or a total spectrum of bamboo spine. So this is probably the best representation of this whole talk, which I picked up from Professor A.N. Malvia's paper, which is available in International Journal of Rheumatic Diseases. So is there an applicability of modified New York criteria in the progression of spondyloarthritis? I would just like to mention there is a cohort study in patients with inflammatory back pain in whom features were suggestive of axial spondyloarthritis. Only 21.1 to 26.6% showed obvious radiographic sacroiliitis. That is, over a period of time, the radiographic sacroiliitis tends to occur in patients with spondyloarthritis or patients with inflammatory backache, and all need not necessarily progress onto radiographic sacroiliitis. So same thing when they are followed up over a period of 5 years in an inception cohort, and with evaluation according to modified New York criteria, blinded to time order, reported only a small net progression in 5.1%. So what we have to know is probably not all patients with inflammatory backache will progress on to have a radiographic sacroiliitis, which we are trying to actually prevent. So what happens in MR? So MRI to detect early sacroiliitis before radiological structural damage. Just like in rheumatoid arthritis, there is a window of opportunity. We are looking at MR, but we have to know how specific or how sensitive is an MR in detecting an early spondyloarthritis or a spondyloarthritis which is usually going to progress on to develop a radiographic sacroiliitis. So that's what we are looking at. And in MR, when we say it's a positive MR, we are looking at inflammatory lesions. Basically, we are tending to look at bone marrow edema and osteitis. But is bone marrow edema and osteitis enough to progress on to radiographic sacroiliitis? Will be the ones that I'll be answering in the subsequent slides. What we have to know is MRI is not all that specific, or bone marrow edema is not all that specific in all patients with back pain, because patients with mechanical strain, I think you would have heard Dr. Vinod Ravindra's talk in the morning. So patients with mechanical strains or vascular signal or artifacts also can have some in inverted commas, inflammatory changes which are depicted by bone marrow edema on the MR of sacroiliac joints. So in spondyloarthritis, more often than not, in the classical teaching, we say that disease starts in the sacroiliac joints and progresses upwards. But what happens to patients or a set of patients who have disease up and then progresses down? Whether that we are really missing those patients in these diseases, we don't know when we are actually using this classification of axial non-radiographic spondyloarthritis. And what is the sensitivity of MRI? I will not dig into the whole table per se. What they have to say is, if they have got in this cohort with 187 adult subjects, only 75 of these patients having ankylosing spondylitis, the mean sensitivity of MRI amongst 5 readers was only 51%. So it's not all that sensitive as well, just like specificity also. And could this be correlated with biopsy findings of this thing? Again, when they do the biopsy of sacroiliac joints in patients with bone marrow edema, only 38% of the patients had a good amount of sensitivity as compared, when they compared these with the biopsy findings. So sensitivities of sacroiliac joints MR define the presence of typical bone marrow edema is only between 35 to 45%, 42% in patients with back pain, clinically considered to be having an early axial spondyloarthritis. So what are the other lesions that we usually tend to look at, or we usually tend to miss when we are looking at spondyloarthritis? One is bone marrow edema that everyone looks for. But what happens to erosions and fat infiltrations? Fat infiltrations or fat metaplasia are becoming one of the more defining features on those who will progress on to develop a radiographic sacroiliitis in recent studies. So when you have a bone marrow picture, or when you, sorry, not a bone marrow, when you have a bone edema feature in MR combined with fat metaplasia, these are the ones that are usually going to progress on to a stage of osteoproliferation and actual bony ankylosis, rather than patients who are having just a bone marrow edema alone. So what are the recommendations? The EULAR recommends that conventional radiograph of the sacroiliac joints is probably the first imaging modality that we should use in all patients with spondyloarthritis or axial SpA. If the diagnosis of axial SpA cannot be established on clinical features or conventional radiography, and axial SpA is still suspected, then MRI of sacroiliac joints is actually recommended. MRI itself cannot serve as a gold standard to make a diagnosis of early axial SpA, because it cannot capture the entire clinical spectrum of this particular disorder. So this is what we have to know, and maybe we are using MRI, I may be right in saying that just like you find normal rheumatoids in a normal rheumatoid factor positivity in a normal population, normal ANA positivity in a normal population, we may not be wrong in saying that we may be finding bone marrow edema also in a normal population, which we tend to overinterpret as a patient to be having ankylosing spondylitis or this thing. So this brings us to the question on what are the predictors of progression in a patient with spondyloarthritis. The strongest predictor is the presence of syndesmophytes at baseline, which can be diagnosed at plain radiograph alone. The inflammatory markers are of course ESR-CRB, smoking, body mass index, and this is quite interesting. Exposure to bisphosphonates in women is also a predictor, is a risk factor predictor for those who will go on to osteoproliferation, primarily because of inhibition of osteoclastogenesis by bisphosphonate action. So this was something interesting that I came across while reviewing literature for this particular topic. And of course, you've got genetic factors. So there is a genetic phenotype, HLA-B27, ERAP1 positivity, and IL-21 receptor positivity. And then you have got receptor protein biomarkers like all these three. So in a meta-analysis, they found that all these predictors, I'm not sure how visible it is from there, but they found that all these predictors, obesity, smoking, male sex, female sex, who are exposed to bisphosphonates, are all risk factors for progression of spondyloarthritis in most patients. So once we have addressed these risk factors and once we have addressed this thing, we come on to the treatment. So what are the current position of NSAIDs. Of course, we know in axial spondyloarthritis, the recommended treatment is only non-steroidal anti-inflammatory drugs or your TNF inhibitors. Sulfasalazine and methotrexate have limited role or limited published data in the progression, in preventing the progression of axial spondyloarthritis. So, symptom control is possible by both NSAID and biologic treatment. Functional improvement is possible by both. And whether both of them stop radiographic progression, we don't have enough data on NSAIDs per se, primarily because beyond 2 years of continuation of NSAIDs, we are more worried about the cardiovascular safety profiles of NSAIDs or the GI tolerability profiles of NSAIDs or the renal problems that are associated with NSAIDs in continuing for a long period of time. So we know that for a shortened period of time, let's say for a period of 2 years, NSAIDs do help in preventing progression of radiographic spondyloarthritis. However, there is growing evidence, particularly in the long-term use with biological treatment in preventing this radiographic progression, but which patient to choose for these particular biologics is the one that becomes in question, and that can always be a point of debate. So we have got several studies to address this, and probably the best evidence comes from the use of secukinumab, and they say that there is sustained or low grade changes through about 2 to 4 years with the use of this particular molecules. However, what we have to know is whether, because MRI or osteitis finding on MRI is only this thing, whether we have to take all these outcomes with a pinch of salt. And currently there are lots of phase 3 trials going on in the use of biologics in non-radiographic axial spondyloarthritis, adalimumab, etanercept, certolizumab, pegol, and golimumab, and this says the ASAS 40 and ASAS 20 response criteria. What we have to know is, till now, there is no one approved drug by the US FDA for non-radiographic axial spondyloarthritis. So we don't have a FDA approved drug for preventing the progression of non-radiographic axial SPA. So whether this entity actually exists, it depends what our future course will actually say. So to sum up, what we have to know is true modification in terms of inhibition of radiographic disease remains an important. Am I overshooting? Can I just finish? It's one more slide. So true disease modification in terms of inhibition of radiographic disease remains an important consideration with regards to long-term treatment with immunomodulated therapies. NSAIDs followed up for a period of 2 to 4, patients who are followed up for 2 to 4 years showed no evidence to support inhibitory effects of TNF inhibitory agents on radiographic progression. By comparison, NSAIDs for 2 years, they have been used, but safety beyond 2 years we don't know, because trials have actually not been continued over a period of 2 years because of adverse events of NSAIDs. So what we have to know is, not all patients will develop radiographic spondyloarthritis. If you have picked up on MR, they need not necessarily progress on to develop a radiological sacroiliitis. The extent of the disease and the point of diagnosis are relevant to the success of treatment. Resolution of acute inflammatory regions of bone marrow edema does not stop radiographic progression when fat metaplasia deposition occurs after resolution of inflammation. So that is why we are looking at whether whether the precursor of osteoproliferation, which is actually bone marrow edema and fat metaplasia, are actually relevant in the treatment of progression of axial spondyloarthritis. And there has to be a greater insight into the pathogenic link between IL-22, IL-23 and IL-17 and early enthesial disease, including periosteal bone formation. I would like to thank the organizers for giving me an opportunity to address this topic. Thank you.
James. No questions, we conclude the session. 1 minute.
Yeah, do you find any difference of using any biological therapy in preventing the difference, where like secukinumab, adalimumab, etanercept, do you find any difference of this thing? Longest progression?
If you are talking about personal experience, I am a person who has used least amount of biologics because it's not very well accepted among my patients. I think there are more seniors who can take up this question, or if they want to comment on whatever Dr. Gupta has asked.
Don't assess radiographic progression, but as far as efficacy is concerned, we assess clinical disease and markers, laboratory markers. But as far as I have used, I have seen adalimumab to be the better one for small arthropathy, apart from other types.
Subbu, nice talk. Only one question. So there was doubtful whether the only edema and other things. Do you recommend repeated MRIs over a period of time so that you can monitor the fat metaplasia or whether the bone marrow edema resolves over a period of time?
So far, there are no these things on doing a repeat MR, but what happens is to look at fat, because there are many more problems that we are picking up on MR. They are trying to correlate MR with CT of the sacroiliac joints, and in fact, they are trying to do whether PET CT is also useful in detecting early this thing. So I'm not sure about repeated MR, but they are trying to combine all these modalities and see whether they can actually pick up all these things. But whether radiology or MR is actually becoming too sensitive, just like a disc lesion that we usually pick up in a back pain, whether it is significant or not, we are not too sure as yet.
So what do you recommend the drug for if you find out, if you detect early sacroiliitis? So you want to stick to only to NSAID and sulfasalazine forever, or you want to recommend FDA not approved, but still biologics if required?
Whatever radiograph and non-radiographic SPA that we have talked about, whatever we are talking about, we still have to know that we are talking about axial spondyloarthritis. So let's say if you suspect a patient to be having axial spondyloarthritis, and if you're trying to catch them early, it will only be over a period of time whether you will know on how these patients are progressing. Till then, probably non-steroidal anti-inflammatory drugs will probably be the better or more logical option to go by rather than my experience.
Rajeshwari.
Yeah, if I may, to address Dr. Gupta's question, resolution of early edematous lesions have been observed after initiating treatment very early in the disease with biologics. This is our experience.
Thank you.
So,
see, this radiological progression prevention and also resolution lesions is difficult. Ankylospondylitis study group, AS is a new criteria. They take an MRI and HLB, both of them. Both are easily comparable. If I recollect my age, 94, at that time not many of using MRI. Patient had bilateral sacroiliac arthritis, X-ray normal, clinically very classic chest X1 decrease, everything. I couldn't go for medications. First time I done a bone scan, then assistant professor nuclear medicine, like Kavita, saw the increased high uptake in both sacral joints. I don't know what it is. There we started, and that patient followed. After 10 years, he developed bilateral sacroiliac arthritis. So, could I prevent it? I didn't have answer. Today, HLB21 marker has come. Here MRI also normal, but sometimes HLB21 negative. At that time, we don't have answer.
Thank you, sir. So,
thank you. If you no questions, we close the session. We are already running 4 minutes behind the session.
5 minutes late we are. So we will directly proceed on with next session, immunosuppression in neuropsychiatric lupus by Dr. N. Raja. I request the chairpersons, Dr. Anup and Dr. Meghna Ram Gawali to take up the dais, please.